This is Anesthesia Circuit with John Kenny, a resource for the busy anesthesia provider and the only show dedicated to all things anesthesia. Listen in your car, at the gym, while you set up your room in the morning, as you cram for a test, or in your free time. Welcome back. I'm John Kenny, and today we're talking about burnout and how to combat that. We're going to talk about some keywords including ASA sedation levels and alpha blocker selectivity. Current research, we're going to discuss beta-lactam cross-reactivity, selecting those antibiotics. We're also going to talk about opioid-induced ventilatory failure, and I'm going to bring you some important dates to remember. Personal health. All right, today, what if I told you that 60% of ER docs report feeling burnt out? Well, anesthesia providers aren't too far behind. 52% of anesthesia providers report feelings of being burnt out, according to a 2017 survey by Medscape. Now, some people may hear this and hear, docs are just complaining about working too many hours. Well, that was only one of the minor reasons people gave for these feelings of discontent. The actual the major themes behind these feelings were actually feeling disconnected from their patients. Feelings of just being a cog in the wheel, too many administrative tasks, and too much computerization of the current practice of medicine were cited as reasons for feeling burnt out. So rather than wanting to work less hours, physicians are requesting and actually demanding more time in front of patients. Tate Shanafelt is a hematologist and physician burnout researcher at the Mayo Clinic. Last June, during a presentation at the New England Journal of Medicine Catalyst event, he said, "We need to stop blaming individuals and treat physician burnout as a system issue. If it affects half of our physicians, it is indirectly affecting half of our patients." With the growing number of administrators in medicine, he also points out that if I told you we had a system issue that affected quality of care, limited access to care, and eroded physician satisfaction, you would immediately assign a team of systems engineers, physicians, and administrators at your center to fix that problem rapidly. He's got a real good point there. According to a 2015 study published in the Mayo Proceedings, burnout affects healthcare providers at a higher rate than people in other careers. Data from the study showed that physicians displayed higher rates of emotional exhaustion and reported lower satisfaction with work-life balance. Burnout primarily relates to your professional spirit of life, and it primarily affects individuals whose work involves intense interaction with people, Dr. Shanafelt said. Now, there are numerous strategies proposed to combat burnout, and those things include things that we can do at home to improve work-life balance, like diet, exercise, and incorporating new hobbies into our life. Now, the Cleveland Clinic took a different approach, and they wanted to do something in the hospital. And what they did was they devised strategies to improve the physician or the patient practitioner relationship. And the way that they did that was they started a training program that was relationship-centered communication. And so rather than adding new things on to a normally busy clinic day, they focused on just improving the quality of those interactions that were already going on between the provider and the patient. The program is called Relationship Establishment, Development, and Engagement. And after the training, the physicians reported improved scores in all three burnout domains. Now, if you'd like more information on this training module and the study results, check out the study in the July 2016 edition of the Journal of General Internal Medicine. Now, also, if you're interested in physician health and wellness, the American Conference on Physician Health is an annual event, and it's scheduled for September 12th through the 14th in 2019 in Charlottesville, North Carolina. If you'd like to present or attend, contact them at physicianhealth, all one word, at ama-assn.org. Physicianhealth at ama.assn.org. So our keywords today are ASA guidelines for sedation levels and the alpha blocker selectivity. All right, let's get right into it. So The ASA sedation guidelines, that's something that's tested very frequently. Oftentimes they're going to focus on things like, okay, how does the patient respond, to a verbal cue or to painful stimulus? That's one category. Another one is, do you have to support their airway or their breathing in a certain way? And then the third of which is going to be, do you need to support them cardiovascularly? Is their blood pressure depressed because of this? So remember those three categories, and that's a good way then you'll be able to remember the difference between minimal, moderate, deep, and general anesthesia. So minimal sedation or anxiolysis is a drug-induced state during which patients respond normally to verbal commands, although cognitive, functional, and physical coordination may be impaired. Airway reflexes and ventilatory and cardiovascular functions are unaffected. So this is an example of this is just a small amount of fentanyl or midazolam. So moderate sedation or analgesia is a drug-induced depression of consciousness during which patients respond purposefully to verbal commands, either alone or accompanied by light tactile stimulus. Now, no interventions are required to maintain a patent airway. Spontaneous ventilation is adequate, and cardiovascular function is usually maintained. And so this is usually a bigger dose of midazolam or fentanyl. For deep sedation, it's a drug-induced depression of consciousness during which patients cannot be easily aroused, but respond purposely following repeated or painful stimulation. So that's the difference. So they'll be aroused easily, or that's one of the differences, with repeated or painful stimuli. The ability to independently maintain ventilatory function, it may be impaired. Patients may require assistance in maintaining a patent airway, and spontaneous ventilation may be inadequate. Cardiovascular function is usually maintained in deep sedation as well. Now, for general anesthesia, it's a drug-induced loss of consciousness during which patients are not arousable even by painful stimulation. The ability to independently maintain ventilatory function is often impaired. Patients often require assistance maintaining a patent airway, and positive pressure ventilation may be required because of depressed spontaneous ventilation or drug-induced depression of neuromuscular function. And cardiovascular function may be impaired. Now, these are a couple of things to remember. Monitor anesthesia care, or MAC, doesn't describe a continuum of depth of anesthesia, okay? Rather, it describes a specific anesthesia service in which anesthesiologist has been requested to participate in the care of a patient undergoing a diagnostic or therapeutic procedure. Also, now, reflex withdrawal from pain stimulus is not considered a purposeful response. So remember that. If the question states, they reflexively withdraw when you pinch them, that's not a purposeful response. So they may be at a deeper level than you thought. Now, also, airway intervention by definition is not required in a patient receiving moderate sedation. Okay. Now, because sedation is a continuum, it's not always possible to predict how an individual patient will respond, and therefore practitioners intending to produce a given level of sedation should be able to rescue patients whose level of sedation becomes deeper than initially intended. So you always have to be ready, and this is part of the guidelines, you always have to be ready to rescue a patient who's gone past the level that you intended. Individuals administering moderate sedation should be able to rescue patients who enter a state of deep sedation. Those who enter or who are administering deep sedation should be able to rescue patients who enter a state of general anesthesia. So being able to rescue means that you have the equipment available to do so. You have the ability to provide positive pressure ventilation. Okay. Rescue of a patient from a deeper level of sedation than is intended by the practitioner, proficient in airway management and advanced life support. The qualified practitioner corrects adverse physiologic consequences of the deeper than intended level of sedation, such as hypoventilation, hypoxia, and hypotension, and returns the patient to the originally intended level of sedation. It is not appropriate to continue the procedure at an unintended level of sedation. So this stuff is right out of the guidelines, directly copied and pasted from the ASA guidelines. Now, the advanced keyword today is alpha blocker selectivity. Now, there are two main types of alpha adrenergic receptors in the body. Alpha-1 are mostly expressed on vascular smooth muscle cells, and when they're activated, they result in vasoconstriction, hypertension, and bradycardia. Now, the alpha-2 adrenergic receptor are present both in the CNS and sympathetic arm of the autonomic nervous system. Within the sympathetic fibers, the alpha-2 receptors are uniquely found on the presynaptic terminals of the postganglionic sympathetic neurons and serve to attenuate further release of norepinephrine. So they're kind of a feedback inhibition. Agonist activity results in the feedback inhibition of sympathetic outflow, thus a decrease in blood pressure and bradycardia. And the analogs for this are going to be dexmedetomidine and clonidine. I can go through some types of alpha blockers. So phenoxybenzamine is an irreversible antagonist of alpha-1 and alpha-2 receptors, but it has much greater alpha-1 effect. It's primarily used in the treatment of pheochromocytoma, as it helps to block the effects of the circulating catecholamines. Phentolamine is also an alpha blocker. It's competitive, reversible antagonist of alpha-1 and alpha-2, and it affects each of those receptors equally. Alpha-2 antagonism can result in positive ionotropic and chronotropic effects in the heart, so that's something to keep in mind. It can be injected subcutaneously to prevent dermal necrosis after extravasation of drugs with an alpha-1 agonist activity. So if you've got that extravasation in there, and phenylephrine or something like that, phentolamine may be able to be injected subcutaneously to help prevent further tissue damage. Prazosin and the other zosins are alpha-1 selective antagonists. They're useful in the treatment of hypertension as well as BPH. Alpha-1 is also expressed in the prostate. And the major side effect of the zosins are orthostatic hypotension. And then yohimbine, that may be tested. It's alpha-2 selective antagonist, formerly used in the treatment of orthostatic hypotension. It's available it's unavailable in the U.S. And then labetalol and carvedilol are both alpha-1 as well as beta receptor antagonists as well. So the featured article today for our current research segment comes from the August 2018 edition of Anesthesiology. And it answers a question that is presented to us almost on a daily basis in the preoperative area. And that question is what antibiotic should I use in a patient who has a penicillin allergy noted in their chart? Now, the use of non-beta-lactam antibiotics because of a penicillin allergy has been labeled a public health crisis, actually, by a editorial in 2014. Now, today the article that we're featuring is entitled "Presumed Beta-Lactam Allergy and Cross-Reactivity in the Operating Theater, a Practical Approach." And this comes from Hermanides et al. Out of the Netherlands. Now, it's an evidence-based and practical approach to patients with presumed beta-lactam allergy in the perioperative setting, and give guidance on the selection of alternative antibiotics based on cross-reactivity patterns. Now, when choosing antibiotics, prophylactic antibiotics, numerous factors have to be considered, and they include surgical indication, pathogens encountered, local resistance patterns, timing, cost, availability, BMI, colonization, immune status, and allergies of the patient. Now, recent studies demonstrate that both the information provided by the patients as well as documented history in the patient file may really lack reliability when it comes to the beta-lactam allergy. Now, one study found that only 2% of patients with reported or documented penicillin allergies actually had a reaction when they were administered the penicillins. Now, the authors of this paper give some steps to approach the patient who says that they've got a penicillin allergy. So you want to clarify the type of reaction. Is this a side effect? Was this a rash? Was this anaphylaxis? So what we see from this table that was presented in the publication, type A reactions are predictable side effects. They include nausea, vomiting, diarrhea. They're not allergies, but they're actually mistaken for allergies regularly. Now, type B reactions are the immune-mediated hypersensitivity reactions. Now, of these, types 1 and 4 are the most important in this article. Type 1 is an IgE-mediated immediate reaction. Now, symptoms range from simple urticaria and angioedema to full-blown anaphylaxis with circulatory shock. Now, this type of reaction can be attenuated by desensitization in cases where they absolutely need this. Now, type 4 reaction is a T-cell mediated reaction, and it's the most common drug reaction. It's delayed and occurs usually 2 hours to several days after intake. So that's after intake. So that's something to keep in mind. So this is a delayed reaction. The reaction is usually a benign rash, and it poses no risk for the development of anaphylaxis. Patients can receive this agent if they've had this type of reaction. They can receive the causative agent going forward with no other risk except for the development of that rash again. Now, also under this category, though, are severe and life-threatening potential complications or classifications of reactions, including toxic epidermal necrolysis or Stevens-Johnson syndrome, drug reaction with eosinophilia and systemic symptoms, acute generalized erythematosus pustulosis, and fixed drug reaction. Now, once again, if a patient has had any of these reactions are life-threatening, and the antibiotic should be avoided at all costs. Now, the authors state that skin tests are the definitive diagnosis. However, there's no time for that in the preoperative area typically. So the anesthesiologist should determine if the symptoms are mild, moderate, or severe. Now, if the symptoms are mild and delayed, then that falls under that category of that type 4 reaction, and you can proceed by giving the patient this medication again. If there's any question about that, though, then I would play it safe and avoid it. Now, the main beta-lactam groups are the penicillins, cephalosporins, carbapenems, and monobactams. Each of these differ in their side chain, their pharmacodynamics, and their thiazolidine ring. And each of these are implicated in the cross-reactivity. Now, the authors have included a useful table that actually shows which antibiotics have common side chains. So in this chart, as you can see, so R1 or R2 indicate that the first or second side chains are the same in these two different antibiotics. And R1S or R2S indicate that the first or second side chain are similar. And so you want to take caution that they may have a higher risk of cross-reactivity in these cases. Now, in all of these cases, they should be avoided in the case of moderate to severe allergic reactions. Okay. Now, also, it's supported practice that all penicillin should be avoided in the case of penicillin allergy. So that's indicated on the top of this table here with all the X's. That if you have a penicillin reaction, everything in the penicillin category should be avoided. Now, one of the most common mistakes when it comes to when people are talking about penicillin cross-reactivity is this number of there's 10% cross-reactivity between cephalosporins and penicillins. Now, that actually comes from old data that was done on first-generation cephalosporins. What this new studies show is that reactivity, cross-reactivity, is way lower, especially because now when we use second and third generation cephalosporins. Second generation cephalosporins have a much lower cross-reactivity, and third generation have no cross-reactivity with penicillins. The cross-reactivity is thought to be caused by the R1 side chain, which most first-generation cephalosporins and a few second-generation cephalosporins share. Okay. A 2015 retrospective study of 1.5 million patients with penicillin allergy received cephalosporins. What it demonstrated was that there was a 1% cross-reactivity and 0% anaphylaxis in those patients. So second generation cephalosporins having side chains similar with penicillins, and some of these are cefaclor, cefprozil, cefoxitin, and loracarbef. Now these ones, there is a possibility for cross-reactivity. Now the other second generation cephalosporins who don't have this similar side chain, it's a much lower incidence of cross-reactivity. Now of note, cefazoline is a first generation cephalosporin, and it's not been reported to cross-react with penicillin. And this is because it has a different R1 side chain. So first generations are preferred in surgical prophylaxis because of their gram-positive coverage and less gram-negative coverage. So cefazoline could therefore be used as an alternative in patients who have a penicillin allergy. The authors have included a flow sheet as well, which is great to help with making decisions in this case. The authors also state that cross-reactivity likelihood should be determined by similarity of side chain and not by the generation of the cephalosporin alone. And that's because the cephalosporins aren't divided into their generation by the side chain as well. Now, carbapenems, in a 1988 study, it found that there was a 47.7% cross-reactivity between penicillin and imipenem skin test. Wow, that's difficult to say for me. Anyway, however, most recent studies have concluded that the number is way lower than that. Okay, so this study said, okay, half people are gonna react when they have penicillin if they are administered imipenem. Now, the most recent studies and the most recent thought is that between 0.5 and 1% of patients will cross-react, that they'll have a penicillin cross-reaction with a carbapenem. Now, also 1% appears to be the number of cross-reactivity between cephalosporins and carbapenems as well. So in the case of a suspected mild reaction to a carbapenem, an alternative beta-lactam for surgical prophylaxis is totally fine. It can be considered. So from all of this, what they conclude is that the actual risk of causing anaphylaxis-related death is as low as between 0 to 7.3 in 100,000. And that's with cross-reactivity. Now, this decision algorithm that they included in the study is a really useful tool for anesthesiologists. It's not absolute, though. You have to take your own local infection patterns, the specific patient that you're dealing with as well, into account when you're making these decisions. Also, what the authors say is don't rely on the test dose. Test dose is something that if the patient is administered a medication that will result in an anaphylactic reaction, no matter what the amount is, it will start that reaction. In the case of avoiding all beta-lactam antibiotics, most guidelines recommend clindamycin or vancomycin for gram-positive coverage, aminoglycosides or fluoroquinolones for gram-negative coverage, and metronidazole for anaerobic flora coverage. Now, in an attempt to reduce microbial resistance, this article provides very useful information for us as anesthesia providers. And this information is definitely going to help us become these optimal antimicrobial stewards that we all should strive to be. Now, as for anesthesia news, the vision of the Anesthesia Patient Safety Foundation is that no patient shall be harmed by anesthesia. Now, this is a simple yet vitally important sentiment shared by anesthesia providers across the board. And that's why I've decided to highlight this article from their newsletter from June 2018. Now, the APSF has adopted an initiative to stop opioid-induced ventilatory impairment and has featured articles addressing this issue in its recent newsletters. Now, according to Dr. Stephen Greenberg, editor-in-chief of APSF Newsletter, a substantial number of preventable deaths and other adverse events are associated with opioid-induced ventilatory impairment, OIVI. The study suggests that it may occur in as many as 1 in 200 post-operative patients. And then between 2005 and 2009, 700 inpatient deaths in the U.S. were directly attributed to patient-controlled analgesia. Now, unfortunately, risk stratification and heightened awareness of this does not identify all the patients who do develop postoperative OIVI, so there's definitely work to be done. The financial and emotional costs of these avoidable outcomes has resulted in numerous regulations and guidelines. One of the most recent and comprehensive of these guidelines is the Joint Commission's R-Cubed report, which was issued in August of 2017. The R-Cubed report, or the R-Cubed, stands for Rationale, Requirement, and Reference. It provides standards for inpatient pain assessment and management designed to improve the quality and safety. The review article that's published in the Anesthesia Patient Safety Foundation newsletter suggests 4 specific ways that hospitals and their medical staff can implement some of these standards in order to help decrease the risk of OIVI. Now, strategy 1 is assessment and mitigation of patient risks for OIVI. So when caring for the postoperative patient and others receiving opioids, clinicians must identify patients who are at higher risk for developing. So it's, point them out, find out which ones are at the higher risk. Strategy 2 is prescribing guidelines and standards. So the R-Cube report requires that hospitals have 1, available non-pharmacologic pain treatment modalities, 2, pain treatment plans based on the patient's history, clinical condition, and goals of care, so a patient-centered pain treatment plan, and 3, specified prescribing practices within the institution. Now, strategy 3 is patient assessment and monitoring standards. They recommend that providers have access to the state-run prescription drug monitoring programs and databases, access to monitoring devices like pulse oximetry, capnography, as well. And then hospitals have standards for screening, assessing, and reassessing pain. And then each patient's pain management plan is patient-centered, based on realistic, measurable expectations, based on treatment objectives, and is paired with patient or family education. So once again, this is the patient-centered approach. This is a very subjective approach here, and not a one-size-fits-all strategy. Strategy 4, engaging the medical staff. So the Joint Commission recommends that an executive sponsor for the Opioid Safe Practices Committee should help establish governments and develop a project charter that's aligned with the mission and vision of the hospital. So ultimately, opioid-induced ventilatory impairment is preventable, and now that we have these guidelines as to how to go about doing just that. And hopefully what this will turn into is less incidents of this ventilatory insufficiency, and potentially prevent morbidity and mortality. All right, a couple of announcements today. So the APSF, the Anesthesia Patient Safety Foundation Stolting Conference, will be held September 5th and 6th, 2018 at the Royal Palms Resort and Spa in Phoenix, Arizona. Sign up today. The AANA Nurse Anesthesia Annual Congress will be held in Boston at the Heinz Convention Center on September 21st to the 25th of 2018. Refresh and expand your knowledge, as well as work with colleagues from across the nation. All right, that's a wrap. Thank you so much for joining us today. We covered some really important topics in the anesthesia world today. Please tell your colleagues and friends to tune in to join us on our channel. As always, if you have any questions, any suggestions, anything for future episodes, please leave them in the comments below. I'll definitely take a look at them and take your suggestions. And we'll see you next time. Information disseminated in this show are for entertainment purposes only. Please consult your professional societies for the most up-to-date information on practice guidelines. Kenny's Anesthesia Circuit is a Vigilant Medicine Media production. Copyright Vigilant Medicine Media 2018.